Welcome to the pain event. Thank you so much for showing up. I'm very happy you're here. You're welcome to grab lunch. We ask you kindly to grab lunch while, keep it reasonable for our speakers to start their talk. So, because we're gonna start a little bit later than we were supposed to start, so we keep the time. I'm gonna go ahead and get the activity going. Thank you so much for coming. We love to welcome all of you. I hope you're enjoying your lunch. I hope we had some good treats for you. And I hope that you have a pain-free day. So how is everybody's doing today? So let me ask you, if you work at Insight, please raise your hand. So the majority of our people are our internal colleagues and team members. So thank you so much for coming. We appreciate what you do. We appreciate you taking the time to join us in this activity. How many of you is from outside Insight? Hi, welcome. Thank you so much for coming. I met you in the elevator. I know you're a family member. How about you, sir? How did you know about the event?
My wife.
Awesome. Thank you so much for coming. We really appreciate it. So today is a pain activity day because September is the Pain Awareness Month. And our theme for the day is compassion, innovation, and healing. Together we transform pain. September is the Pain Awareness Month, and that was announced by the International Association of the Study of Pain. And that tells you something, that pain is global, it's a worldwide problem. And they dedicated a month for its awareness and learning about the complexity of the problem and what treatment options we have. So today, we're gonna have 1 hour lunch and learn. We hope that you have a good time and it has no pain whatsoever. I hope there is some chocolate because food and chocolate are good pain reliever, especially around lunchtime. If there's coffee, that's even better. So in the States, pain is a national health problem. It's a public health problem. In the last 30 years, there was significant burden on our healthcare system with financial losses and high costs for care, plus the high loss of productivity. So it's a multi-layer problem. And unfortunately, in the United States of America, according to the CDC statistics in 2021, we have almost 21% of the US adults suffer from chronic pain. And that costs billions and billions of dollars every year to care for these patients and to accommodate for the loss of their productivity. The other thing that is interesting about the statistics is chronic pain is higher incidence than chronic problems such as diabetes and hypertension and depression. So we have a significant public health problem. And it's a great opportunity to team up with you, to talk with our community, our patients, our family, because pain management is very hard and it's definitely not one specialty, not one man job, it's everybody's job. And today is a good opportunity to team up, open the dialogue, and see how we can build bridges with our patients, our community, our healthcare providers to really transform pain towards healing and prevent chronic pain. So thank you so much for being here today. This is the first step. So before we go further, we have to review some key concepts of what pain is and pain pathway, and to be able to understand what other modality we can offer these people to support their pain management strategy. So pain is defined by the International Association of Study of Pain as any unpleasant sensory and emotional feeling or experience that is triggered by actual tissue damage or potential tissue damage, or described by a patient as so. So that's very important key concept here, because there could be a tissue damage and there could be potential tissue damage, but sometimes there is none. But the patient says he does have pain. So what do we do about that? So that's what's unique about pain, because it's hard to measure, it's very subjective. And I like another definition that's a lot simpler that was done by one of the pioneer pain nurses 30 years ago. She says pain is whatever the person experiencing say it is. So the bottom line in simple words, pain is subjective, pain is real for the person who's experiencing it. We cannot judge other people's pain or say, no, they're not having pain, because different people feel pain differently. It's an individual experience, it's multi-layer, it's very complex. So those are key concepts that we cannot do a pain awareness activity before, clarifying those. The other key concept is differentiating of types of pain. I'm not going to be very technical in the language we're going to use for this presentation because I was hoping there's more like community, guests and patients and family come. But sometimes we have to go through like some basic pathophysiology. So it's a sophisticated words, nociceptive neuropathic pain. In simple words, it's like either pain associated with nerve injury or pain coming from inflammation or fracture. So nociceptive pain is usually the kind of pain you have if you got injured, like such a fracture, like fracture arm, that's nociceptive pain. Whereas neuropathic pain is something that you get if you have nerve damage. So like you have peripheral neuropathy, diabetic neuropathy, or chemotherapy-induced neuropathy. So nerve damage is associated with the pain problem. The pain pathway is another key concept that we really need to review to understand what different pain modalities and strategies we have. So pain usually starts with triggering injury in the peripheral and is transmitted through the pain nervous system, which is the C fibers, A delta fibers, to the spinal cord, and then to the executive brain where we perceive pain. So those are the sophisticated processing of pain. And the key concept I would like to highlight significantly here is something called modulation. Modulation means that we don't have like rigid wiring of our pain signal, because any pain signal in the nervous system is an electrical signal. So you have a pain signal, which is like an electrical signal in the peripheral system that travels through the spinal cord and the nerve to the higher executive brain for us to perceive pain. But those wires are not rigid wires, they're dynamics. We have inhibitory and excitatory pathway, upward, ascending and descending pathway. So that's what automodulation or autoregulation is. And we, as pain physicians, offer a lot, and the newer technology and the research now is offering a lot to our patient, working with modulation to modulate the pain signal along the pain pathway. So that's an important key concept to also review. The other issue is the different type of pain regarding to its duration and time. Pain could be acute or chronic. Acute pain usually is associated with an acute injury or acute illness. Usually it's short-lived. Once the illness gets better or the injury healed, the pain should go away. But what happens when the pain doesn't go away? That's the problem. That's called chronic persistent pain. And it's really bad. And that's why we're having this pain event today. That's why we have a pain awareness month. That's why I went to pain management. Because chronic pain is one of the nastiest human experience a person can feel. And chronic pain is multidimensional. It doesn't stay with the physical pain. It escalates like a snowball to emotional pain, and cognitive pain, and problem quality of life. And it's really disabling. So chronic pain is a real significant problem. And one of the definitions is the International Association of Study of Pain again, define chronic pain as pain that lasts more than 3 months, and it's not responding to normal pain management and is outlasting the initiating event. Or sometimes there is no initiating event. Like I can give you some example. Myofascial pain syndrome, one of the nastiest chronic pain syndrome, and there's no initiating event. You just wake up one day and you're hurting all over. And it's real for the person who's experiencing it. Sometimes you can identify initiating event, but in chronic pain, sometimes you cannot. And the patient is having real pain. So the other thing that we have to make sure we understand is the impact of chronic pain on the quality of life and ability to do general activity. So one other concept I would like to review with you today is the normal response to pain and how chronic pain really messes our system in a way that we process pain signal, because it's normal to have pain response, and that's actually one of our defensive mechanisms as creature to avoid harm. But if I burn myself, I want to know, so I will draw my arm so I don't continue to burn my arm without feeling it. So pain is protective. We need this for our survival. That's a normal physiologic pain response. However, when we have chronic pain, everything is messed up. Like, the nervous system goes out of whack. That's what happens. So acute pain is a normal pain response. Like if I'm doing surgery, that's acute pain. If I fracture an arm, that's an acute pain, and that's normal pain response. I increase pain intensity. In response, I have increased pain intensity. However, with chronic pain and neuropathic pain, there is a shift to the left, which means I might not have a painful stimulus. The pain intensity is zero. The painful stimulation is zero. And that's called allodynia, when you have pain to touch, which is very common in chronic pain and neuropathic pain syndrome. Allodynia And then hyperalgesia is when you have amplified, exaggerated pain response to, to a painful stimulus. So like even if you have a painful stimulus, but like your response is very amplified and very exaggerated. And that's what the term called neuroplasticity. We talked about that the nervous system is not hardwired, it's dynamic. It can learn pain, it can memorize pain. It just go crazy, it's go out of whack. So we need really to understand this concept to be able to effectively treat chronic pain and neuropathic pain effectively. So what do we do? Whether you have acute pain or chronic pain, it's a complex problem. So any complex problem needs a plan. It needs a map. It needs a systemic approach. So what's the first step in management? The most important first step in management is evaluation. We have to assess the pain. And we said that pain is subjective, whatever the person says. So like how as we healthcare providers can measure it? Like do we have a pain measurement device like blood pressure? I wish. We have to go with what the patient is telling us. So one of the common tools that we use is the numeric scale, which is 0 to 10. And it's an analog scale. We ask patients, you don't know pain in the worst pain ever, what's your pain score right now? It's important to know that this scale is good for people who can understand the scale and they're able to verbalize their pain. But there's a lot of other scales that our hospital inpatient units, ICU, they use also to assess pain. And this scale is good to assess acute pain because you titrate pain medication according to the pain score, like 0, no pain, in the worst pain ever. You want to make sure your patient, like post-surgical, is not, here or here. You want to, like mild pain is here, right? And the faces analog scale is good because if you have a language barrier or a child, they easy can like point at the face. So this is a good scale, very widely used tool, but it's good for acute pain more than chronic pain. In our pain clinic, we use the PIC scale, which is a 3 rating system that rates the pain intensity, the quality of life, like your ability to engage in enjoyment with your friends, your walk, like your family, your work, and the ability to do your daily activity. So the P for pain intensity, E, enjoyment, and G, general activity. And you see for chronic pain, we need to know your pain on average. So we average this 3 scale rating over the last week or 2 weeks, and we take the average of those 3 scores. So this is how we assess pain, although it is subjective. Now, talking about systemic approach and the ladder approach, the famous WHO ladder, this is the World Health Organization, worldwide adopted very, very widely for pain management. Initially, it was published in 1986, and it was meant for cancer pain. And you'll see that it really gives guidelines on when to start opioids. So if you have mild pain, the first pain, like the first step would be non-steroidal anti-inflammatory medication, paracetamol. You still have pain, you do weak opioid. You still have pain, now you move up, escalate to strong opioid, like methadone or fentanyl, right? So there's a big issue with this ladder. Over the last 30 years, there's a lot of research and updates criticizing the ladder. And people think it contributed to the opioid crisis because healthcare providers were over-prescribing opioid, and then we ended up with a bigger problem than chronic pain, that's opioid crisis pain and opioid use disorder, people losing their lives. So it also ignored that pain is multidimensional. It's an emotional, complex nature of pain, coping mechanism, and psychosocial comorbidities. So there's a lot of criticism, right? It's really lacking. So more updated ladders were suggested in the literature. This is one of the most updated, published in 2020. However, I want you to note that all these ladders and guidelines are designed by non-pain physicians. They're designed for people who don't have access to advanced technology. Remember, the source of that ladder was the World Health Organization that gave guidelines to the entire world, the countries who might not have access to advanced research, advanced technology. So the only access they have to is medication and opioid. So they gave them guidelines. And this one, the revised one for non-cancer pain, you see they put minimally invasive technique as step 3. So they added 1 step to the ladder, and they put it as step 3. And they put integrative medicine like acupuncture throughout the steps. So me as a pain physician, and I agree with all pain physician society in the United States, we kind of like not really in full agreement with this approach because we think we are involved from the beginning, from step 1. If you really want to help the patient, you really want to prevent pain, you want to do the best you can from the beginning. prevent chronic pain. Do minimally invasive technique from the first step. Don't wait until things fail you. Because remember neuroplasticity? Chronic pain is learned. And it's very hard to unlearn something. It's easier to prevent it. Like prevention is better than treatment. I mean, we still can offer a lot of treatment, try to help the patient. But we prefer to be involved early on. So what do we do at Insight? This is our philosophy. First, compassion, empathy, understanding our patients' concerns and their pain, really connecting with them and their family, understand what's the problem with assessment. Innovation, that's our edge. I'm very happy that I work with a team of physicians, highly talented, highly equipped with excellent skills. Dr. Vaughn, she's our neurologist. She can do neuroconducting studies. She can offer a lot of intervention. Dr. Sagarwala does a lot of neuromodulation. He does spinal cord stimulation. They're both going to teach us more about things they do in the clinic. But we're very fortunate to be with a team that can offer top-notch technology to help people early on. And then healing. We hope that we help people heal. We hope that we have good outcome by going back to normal life or at least acceptable quality of life. That's our goal at Insight. And we do adopt whole person. So we do care about our patients, our family, our community. And that's part of our care today is organizing this community event. We never forget about comorbidity with psychosocial disorders or coping maladaptive behavior like anxiety, depression, which is very common. I wish we had a behavioral health representative today with us because we need to coordinate the plan for pain management with them very closely. It's very rare to have chronic pain without having anxiety, depression, and sleep disorder. And this is behavioral health specialty, so we coordinate with them. This is our pain brochure you have print out. This is our providers. They're all excellent. If I have a pain problem, I wouldn't hesitate to go to Dr. Vaughn or Dr. Sagarwala. They're excellent, professional, highly equipped, highly qualified physicians, and I'm very happy to be in one team with them. We offer a lot of services, including medication injection, spine injections. We do recommend physiotherapy that Kurt, my friend from inpatient physiotherapy, senior physiotherapist at Insight. He's going to teach us a lot about physiotherapy and the importance in rehabilitation and physiotherapy early on with chronic pain management. So I'm going to leave him elaborate more on that. Acupuncture, I'm a big fan of acupuncture. If you read my bio, you'll see like I'm interested in medical acupuncture. I studied acupuncture, I believe in it. I think it's part of neuromodulation. I mean, when you do acupuncture correctly, you might be able to help the patient with minimally invasive technique. So that's the stuff we do in Insight, and this is one of the most recent cases I've done last week, actually. This is peripheral nerve stimulator implant under ultrasound guidance for intractable knee pain. This is going to stay 60 days for treatment course with neuromodulation, try to rehabilitate the pain signal of the peripheral nervous system. So this is part of the innovative technology that we do, top-notch advanced technology. You know, this is the most advanced techniques that Dr. Sagarwala will be speaking more in his lecture about what we're offering with advanced technique too. So I'm not gonna take more time on this, but the most important thing that I don't wanna I cannot overemphasize is the team approach and the beautiful people that I work with and I'm fortunate to team up with. Vaughn, I wanna give you a shout out. Our OR nurses, they help us do our procedures, they help us take good care of patients, they're compassionate, they really attend to patient needs. Our anesthesiologists, I don't know if Dr. Pitar is here, but our anesthesia department, they're very nice, they provide sedation when the patient is very anxious. And definitely, last but not least, our pain clinic team, our MAs, our front desk. Ricky, are you here? Ricky's not here. Ricky is a nice guy. He's a really nice gentleman I work with in the pain clinic, and he really helps take care of his patients. So again, team approach cannot be overemphasized. And finally, I would like to thank Julia, because she was really the real champion organizing this event. Thank you so much. Without further ado, I will present Dr. Vaughn. Please, you can come in. Cheers.
everyone, I'm Shanele Vaughn. I'm going to talk a little bit about head and neck pain. So I'll open with a little personal experience. I've had, intermittent, I would say mild to moderate neck pain for a long time, nothing that I couldn't take Tylenol or ibuprofen to deal with. Then in the spring of last year, I woke up with severe neck pain, and it went on for maybe like 6 to 8 weeks. And it was a great learning experience for me to understand what patients experience, because when I tell you that it was all encompassing, I mean, at times I felt like I couldn't focus on things that my family was saying to me. I had a hard time doing tasks around my house because it was all I could think about. This neck pain, it was in my head. It was very severe. And so, I did a little PT and got better, but it really helped me to understand when people come in and they say they're in 10 out of 10 pain, 9 out of 10 pain, what that really means. So for neck pain, there's many reasons why one would have either acute or chronic neck pain. So the first reason I'll speak about is here. So this is arthritis. So we have joints in our cervical vertebrae. These are these red joints here. And they sort of, I like to say, stick the vertebrae together. So we have our joints that should be, we have our vertebrae that should be stacked, on top of each other nicely. We have discs between them, and then they sort of stick together with these joints that we call facet joints. And so these joints are true joints, and as we get older, because of gravity, bad posture, tech neck, we're on our phones all day, carrying excess weight, etc., we can develop arthritis in them. And so we may call that facetogenic pain, or we may call that cervical spondylosis. When we get arthritis in these joints, they become thickened, they can grow these little outgrowths that we call bone spurs. And so, as you can see in the picture here, when they're thick and they have these outgrowths growing from them, then there's nerves here in the area. And so it can push on these nerves and it can cause a significant amount of pain. So in this case, we may consider doing, medications, PT. We can do what's called a facet joint injection, where we put steroid into the affected joint. We can do what we call a medial branch block, where we would sort of put local anesthetic to numb the nerves that supply sensation to those joints to see if that's actually the location of the pain. And we can also do what's called a radiofrequency ablation, in which we denervate those nerves, and that can last for 6 months to a year. Another common cause of neck pain is cervical spinal stenosis. So this is our spinal cord, and it should live in a canal. It should be nice and open and be surrounded by our cerebrospinal fluid. Also, because of all the factors I mentioned earlier, as we get older, this canal can become narrow, and it can push on your spinal cord, and your spinal cord does not want to be touched. And so when that happens, in addition to all the significant neurologic problems one could have with their ability to use their arms, to feel their arms, to use their legs, to feel their legs, to walk smoothly, you also can have a significant amount of pain. So for this, we may offer an epidural steroid injection and some of the other things that I spoke about previously. Here, we have cervical radiculopathy. So this, again, is our spinal model. And these little yellow nerves coming out here, they grow off of our spinal cord. We call them the cervical nerve roots. And they exit your spinal canal through these little holes called a neuroforamina. And they go off down your arms to do their jobs. So depending on what spinal level it is, it may go to your elbow, it may go all the way down to your fingers. And again, those don't want to be touched. So if you have a disc that's out of place, you have a bone spur, you have a narrowing for whatever reason, you have a cyst there, you can have a significant amount of inflammation and pain in those nerves, and you may not feel any pain in your neck. You may feel pain, in your shoulder. You may feel pain in your hands. You may have numbness in your hands and think that you have carpal tunnel syndrome. So for that, we can do multiple injections as well, different kinds of epidurals. And then this is a common cause. I would call this myofascial pain. So we have a lot of muscles, nerves, and tendons in our neck that, whether it's using the wrong pillow, or it's just stress, or you have some sort of job where you're turning your neck all the time, or like I said, tech neck, bad posture. You can have whiplash injuries if you're in an accident or you fell. And this can cause a significant amount of myofascial pain, which might be tendonitis or tendinopathy or a muscle spasm or muscle soreness. And so this may be as simple as just doing something called a trigger point injection in the office, in which we would inject a little bit of local anesthetic, mostly just so that the needle itself is not painful. And then the local trauma that the needle causes to the muscle actually releases the muscle spasm. A lot of times myofascial pain is not just myofascial pain, it's secondary to one of these deeper down problems that we talked about. And in that case, we may start with the trigger point injection, see what kind of relief you get from it, see how long it lasts, and then move on to something slightly more invasive in the future. This specific kind of pain, I like very much to collaborate with PT, because they can do myofascial release and a lot of different kinds of techniques to help with that, and also help teach you how to just navigate your world in a way that won't continue to exacerbate your neck pain. So next, I'll speak a little bit about headache syndromes. So the head and the neck are very closely related. A lot of those muscles I showed you in the last picture, they actually insert into your skull. And so if someone has chronic headaches, they can have chronic neck pain. And if someone has chronic neck pain, they can have chronic headaches. So this list of headache syndromes is by no means comprehensive, but these are sort of the most high yield ones. Cervicogenic headache here would be coming from some of the causes that I discussed previously. Cranial neuralgias is both facial and head pain that comes from some sort of inflammation or just like dysfunction of one of your cranial nerves. So common ones would be like occipital neuralgia, which that's what this is showing. So your occipital nerves come from your upper cervical spine. You have some that come up the back of your head here, and then you have some that come around this way. So sometimes people say they have pain on the top of the head, and the back of the head, and the temple, maybe across the forehead. There's also supraorbital neuralgia, which you would think about, say, like a swimmer. It doesn't have to be, but classically you would think maybe a swimmer who's wearing goggles. You have like nerves here that it presses on, but it doesn't have to be in that case. And then there's multiple other kinds of cranial neuralgias in which we can do various injections for. Migraine headache is probably what most people would use as a term in their everyday life. People tend to refer to migraines as a very severe headache, when a migraine headache is actually a very specific headache syndrome. You can have other kinds of headaches, such as the ones listed here, that can be as severe or more severe than a migraine. So migraines generally are on one side of your head, most often behind the eye. They're usually pounding in quality. They last like 45 minutes to 4 hours, and they should be associated with one of nausea, vomiting, light sensitivity, or sound sensitivity. For migraines, we usually would start with like medication management. It's sort of like we have lots of medicines, but we're all made differently, and we just never really know which one would be best for you. So a lot of times in the beginning, it's a lot of back and forth of us like titrating the medicines, trying different medicines to see what helps. If that doesn't work, there's other therapies such as what's called a sphenopalatine ganglion block that I won't speak too much about because at the moment we don't have the device here, but I'm hoping to get it soon, and that's also something we can do very easily that can be very effective for headache. Then there's tension headache, which we all talk about like when we're stressed. We're like, this pain that goes across here and a band around the head. And I lump that with myogenic headache being from muscles, because we have a lot of muscles, like around our face and in our head, like I spoke about. And when we're, stressed, we have like changes to our diet, we have changes to our sleep schedule. You can have a spasm of these small muscles and have these tension or myogenic headaches. And then cluster headaches, which some literature, they would refer to them as the most painful headache known to man, to the point that some people call them suicide headaches. They are focused behind your eyeball here. They can cause your eyelids to droop. They can cause your nose to run. They can cause you to have tearing, all on the side of the pain. They're very, from my, the feedback I've gotten, they're extremely intense. And then, we have to get kind of creative about how we treat that. I won't go into detail, but so this is just like a few of probably the most common headaches that we would encounter in like the primary care office, in the emergency room, in the pain clinic, in a neurologist's office. And like I said, like similar to as Dr. Jabri mentioned, we would like to use multimodal therapy, meaning medications, interventions, their PT, acupuncture, etc. So thank you.
You could just skip the first page, though, because like it's just the title and everything. And then which should I press here? Okay. Hello, good afternoon. So I'm currently a physical therapist, basically assigned like in the acute floor. So I just want to get like an answer, like with regard to like, is everybody familiar with what PT means aside from physical therapy? What's the acronym? What's another like word or meaning of PT? Anybody? Has anybody heard of pain and torture? Or sometimes we're called physical terrorists. And aside from that, actually, I've been called a lot of times as a drill sergeant. But, however, we could be the patient or the person's best friend, or we could be an enemy, but of course, we try to avoid being an enemy. Our goal as a physical therapist is once we get the consult from the doctor, number one is we do conservative treatment because we want to prevent like surgery or any aggravation of symptoms. So we usually start with like outpatient. So before patients go and have like a total hip or a total knee or a total shoulder replacement, we do conservative treatments wherein we do assess the patient and see what is going on. And with that full assessment is we can incorporate what modalities we use. Different modalities are we can use like from a simple hot pack, cold pack. We have like iontophoresis where we use like some drugs with the machine and it's induced in the patient's body. We use electrical stimulation, biofeedback, TENS. I did not include this here because I thought it was just going to be like a 5 minute spiel. So, but if you do want some information, you could just call our unit and we could give you more. Now, what I did here is it's more of like I just kind of cut it down into different stages of how we deal with the patients who have pain or even just like regular physical therapy interventions. So first part that I did mention is the conservative treatment via outpatient. Now, we do have the acute care. Of course, they're more unsteady, unstable. They're more, or they do have more of the acute pain. So aside from pain medications that we have to make sure that the patient gets at least half an hour, 45 minutes or an hour prior to the start of therapy, we do have to like discuss how the patient feels, how they move around, what their prior level is. So we do use like the therapeutic interventions or modalities like what I have mentioned, but in most cases though, the goal is we have to get these patients out of bed. Early mobilization is important, post-surgery, post-trauma, or debilitating, because like 3 days of being in bed is equivalent to a whole week that you've already lost. So that's why, you know, they just keep being like overnight. What happens is like when you get up in the morning, like every part of your body hurts. And as we age, that's what happens. So you kind of have to stretch out, move. And as the day goes by, you know, it feels much better. It's not 100%, but at least, you know, the mobility, the movement, the stretching is very important. And that's part of the education that we give the patients. So once you're done with acute, so we kind of have to decide, is the patient going to need, or is the patient able to go home? Do they need to go to a rehab facility or to a subacute place? So we have what you call an acute inpatient rehab, wherein the patient has to be able to tolerate 3 hours of therapy 5 days a week. Or it could be broken down to like 15 hours for the whole week. So that's acute inpatient, such as Schwab or Shirley Ryan. And then we also have the subacute, wherein patient can tolerate less than 3 hours, but they stay there longer. And again, intervention-wise, it's all going to be similar with regards to like pain management, but it's all about function. We have to get these patients to move, have to get these patients to sit up for at least an hour to 2 hours, 3 hours, or the most, depends on how they tolerate it. And then if they can walk, then we do include them. Now, after the acute inpatients, we have, once they're done with that, next part would be home health. So goal is for them to return home to see how safe they are. We have home health therapists. So the goal, again, is to ensure that they safely transition into their home environment. And of course, with regards to like pain management, we also do the pain education. What kind of pain education we do? So it's a lot of like compensatory strategies. You gotta modify your way of living, positioning, doing your exercises every day. Studies show that the most number of repetitions with regards to exercises that we have to give a patient is just 5 repetitions. Because if you even give more than 5, patients don't really follow through with it. They're non-compliant. That's why the family has to have a great role with regards to like pushing or encouraging the patients to move around. The last part would be outpatient or workman's comp, especially if the pain or the injury is because of is work-related. So you progress to improving function and aided or restoring the ability to go back to work. So we have the work hardening program, wherein before the patient goes back to work, the therapist has to assess this individual if they are appropriate to return back. Any questions so far? Okay, none. So let me just do a quick discussion about the spine, which Dr. Sagarwala will actually talk about anyway. Anybody familiar, or how many vertebrae do we have total? Come on.
32.
Initially, we have 33 bones. So we have 7 cervical, 12 of the thoracic, 5 of the lumbar. We have 5 of the sacral and 4 of the coccyx. Okay. What happens there, though, as we hit 20 years old till middle age, the lower part fuses. So it goes down to 26. Your sacrum will fuse from 5 to 1. Your coccyx will fuse from 4 to 1. Why am I talking about this? Because it's very important that you know how the spine is kind of situated as well as forms. We have like what we call the normal curvatures of the spine. So you have the primary curve, which is the lordotic curve, or rather the kyphotic curve. So while we're in the fetal position, the baby's inside the mother's womb, right? So we're all flexed. So that's the kyphotic posture. We have what you call the secondary curvature, wherein it actually changes for the neck and your lower back. Once the infant or the baby starts pulling their head, it extends and they go into a lordotic. Once the baby or the infant starts to sit up, the lower back will switch from a kyphotic to a lordotic curve. Why is this important? Especially when you're doing your job or when just like regular activity. If you do the opposite or an excess stress on this, you're going to feel the pain, especially like the lower back part. Okay. Now, with regards to the lower back, they say that about 80% of Americans will be having or will be complaining about lower back pain within their life. Back pain is actually the third reason why we go to the doctor's office, which is secondary to skin diseases as well as arthritis. And it's actually number 1 reason why we get debilitated that we can't go to work. Okay? Pain. With regards to the pain for the back, it could either be arthritis, it could either be osteoporosis where the bones get brittle, it could be a herniated disc, or it could be muscular and ligamental. So these 4 are what us therapists kind of addresses, and we just do our interventions according to what we see or what we do. Okay, and I will turn the floor to Dr. Rasha. Sorry about that.
All right, good afternoon, everyone. My name is Dr. Sagarwala. I'm an anesthesiologist, interventional pain physician, as well as the chairman of the Department of Pain Management. Thank you all for joining us today. Thank you to Dr. Jabri for spearheading this initiative, Dr. Vaughn, Kurt from physical therapy, as well as Julia for helping coordinate this event. We're going to talk a little bit about chronic pain and specifically some of the advanced pain therapies that we offer, particularly neuromodulation. So this is a little bit of a recap. We talked about the definition of pain and how it typically will go away after a period of time. Normally that's about 4 to almost 12 weeks after an acute injury has healed. The problem happens when pain is persistent in that subacute phase between 4 to 12 weeks. We really have a very important window of time that we can help address the pain at that point, decrease the risk of it developing into chronic persistent pain. We talked a little bit about chronic pain, how it's a very complex biopsychosocial disease in and of itself. Typically is ongoing for at least 3 months in duration. Now, another term is high impact chronic pain, which is chronic pain that really functionally limits folks for most days over the past 3 months or so. Now, the NIH has sent a survey to individuals across the country in 2021, and it showed that the prevalence of chronic pain was 21%, and high-impact chronic pain was 8%, which is quite significant. As Dr. Jabri had alluded to earlier, the incidence or the rate of new cases of chronic pain is actually more than some of the typical chronic medical conditions that we see, such as hypertension and diabetes, so a very widespread problem. In response to this chronic pain epidemic, as well as the ensuing opioid epidemic, there's been a lot of work on creating best practice recommendations for all healthcare providers who manage chronic pain. Now, this particular group was assembled by the U.S. Department of Health and Human Services. They created an interagency task force with various stakeholders involved in the treatment of chronic pain. And in 2018, they actually released best practice kind of recommendations. It's not necessarily guidelines, but recommendations. And some of the key points there were, one, an early consultation with a pain specialist to accurately diagnose the pain generated. A lot of her treatment is predicated on having the right diagnosis. If you don't have the right diagnosis, your treatment will likely be ineffective. 2, having a very goal-oriented focus, not only on pain relief, but also functional improvement, quality of life. Those are all very important aspects of pain management as well. And probably the biggest point was an individualized, multimodal, and multidisciplinary approach to addressing chronic pain, with the integration of some interventional pain procedures when appropriate. These can include things such as neuroblocks, epidural steroid injections, radiofrequency ablation, and some neuromodulation options we'll talk a little bit more about. 2 of the most common conditions that we see are, 1, chronic lower back pain without leg pain, as well as painful diabetic neuropathy. Now, neuromodulation has become a more and more established treatment option for these particular conditions, and there's quite a bit of evidence that has come out to support this. So what is neuromodulation? So neuromodulation is defined by the International Neuromodulation Society as the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation, to specific neurological sites in the body. Now, there are many examples of this throughout medicine. You think of about cardiac pacemakers for individuals that have abnormal heart rhythms, deep brain stimulation for individuals with Parkinson's disease, movement disorders, sacral nerve stimulation for pelvic disorders and bowel incontinence. There are multiple neuromodulation options that are involved in chronic pain care as well. So this is a picture of a few different options that we utilize. These include things like peripheral nerve stimulation, spinal cord stimulation. Depending on where in the body these are targeted, what neurologic sites are being targeted, they generally will all involve placement of a temporary or permanent electrode array connected to an external or an internal receiver and or pulse generator, which serves as a battery or power source for the device. Now, we could talk about this neuromodulation options in chronic pain for 2 hours, but we'll focus on high-frequency spinal cord stimulation. Now, what is spinal cord stimulation in general? Spinal cord stimulation involves the delivery of gentle electrical impulses to the spinal cord to block pain transmission as it's coming up the spinal cord and being processed in the brain. Now, typically this kind of a therapy has been utilized for people who have a condition called failed back surgical syndrome, which is kind of a catch-all term for people who have persistent pain after spine surgery, as well as for complex regional pain syndrome. Now, historically, spinal cord stimulation has involved low-frequency tonic paresthesia-dependent stimulation. Now, what does that mean? Essentially, the stimulation that's delivered would feel like a kind of a tingling or buzzing type of sensation over the area of an individual's site of chronic pain. Now, over the past 10 to 15 years, we've had a pretty rapid expansion in the technology involved with spinal cord stimulation, not only in terms of the hardware, but also the software. In terms of hardware, we've seen that these devices get smaller and smaller every year, to the point where they're almost miniaturized devices. As you can see in this top left-hand corner, that receiver is about the size of a dime, and that's the largest component of the system that's under the skin. Now, what's even more exciting is the advancements in the software. Now, the waveforms that are being delivered, we have developed new waveforms. Those are in particular high frequency or 10,000 hertz stimulation, as well as burst DR stimulation. And these new stimulation paradigms have been shown to be much more effective than more traditional tonic forms of stimulation. If you think about the general success rate with the older forms of spinal cord stimulation, about 50% of people will have at least 50% improvement of their pain. Now with these newer forms of stimulation, we're seeing that it's closer to 80% of people have at least 50% of their pain completely gone and long term. In addition to some of the advancements in these new waveforms, there have been new indications or FDA approvals for certain conditions. And that includes patients with painful diabetic peripheral neuropathy, as well as individuals with non-surgical axial back pain. Now, these are typically treatment options for people who have failed the conservative treatments. So they've done physical therapy, they've tried medications, they've tried some basic injections and maybe some other procedures, and they really are not getting much relief, and it's significantly impacting their daily lives. Now, what differs about high-frequency spinal cord stimulation compared to traditional tonic stimulation is, one, we talked about how it is generally much more effective for various conditions. Another important feature of this is that it is paresthesia independent, meaning that patients who have this kind of a therapy don't feel that kind of a buzzing, tingling sensation over their area of pain. They actually don't feel anything at all. So this is something that is safe for them to use when they're sleeping at night or when they're driving their vehicle. With traditional forms of stimulation, it would require the device to be off. lot of words on the slide here, but this is just one study looking at this new indication for non-surgical axial back pain. Level 1 randomized controlled trial that was published in the Journal of Neurosurgery and Spine about 6 months ago. And it looked at about 159 patients who were randomized to either conservative treatment or treatment with high-frequency spinal cord stimulation. And you can look at the bar graphs on the right. In that top left portion of the graph, you'll see the 6-month results in terms of the primary endpoint being at least 50% improvement in their pain. And that was about the 80% mark at 6 months compared to about 3% at 6 months for conservative treatment options. Now, this is another study that was done after the previous one that is a real-world study. So, it's important to be very skeptical of some of these clinical studies because every factor is very well controlled. And a lot of these things may not translate into the real world where we know there are a variety of factors that are involved that kind of limit the success of certain therapies. So what's exciting about this study was it looked at 1,660 patients, multiple centers across the world. A lot of these were primarily based in Europe, but it did include some US population as well. And the bar graphs on the bottom right, you can see the degree of at least 50% relief at 12 months in this real-world study was 77%. So it did confirm the findings of the previous randomized controlled study that was done. There's a little animation here to kind of talk about the process of HF10.
A breakthrough treatment for chronic pain is here. It's HFX, a spinal cord stimulator, or SCS treatment option. HFX incorporates the most advanced SCS available, offering the widest range of frequencies and waveforms available to individualize your relief. It's FDA approved and is the only SCS system demonstrated to provide more people with significant relief from back pain, leg pain, and pain caused by diabetic neuropathy in clinical studies. Even people who have tried surgery and medications in the past may be good candidates for HFX. In fact, 8 out of 10 people who used HFX for severe chronic pain experienced a significant reduction in their pain, allowing most people to return to everyday activities and get back to what they enjoy. With patients suffering from chronic pain, abnormal pain signals are sent through the spinal cord to the brain. The HFX solution calms the nerves that carry these signals to provide lasting pain relief. In a simple procedure, thin insulated wires are placed in the back near the spinal cord and connected to a small implanted rechargeable device. The device sends mild electrical pulses to the spinal cord to calm the nerves and reduce chronic pain. The procedure involves a relatively quick and minimally invasive outpatient procedure, which means you will likely go home the same day. You can use HFX 24 hours a day, including when you drive or sleep. Before committing to the procedure, you'll complete a 1-week trial where you and your doctor will assess its effectiveness in managing your pain. During the trial, the 2 wires are inserted in the back near the spinal cord and attached to an external battery. 9 out of 10 people who try the HFX solution stay with it. Ask your doctor if the HFX solution is right for you.
Nice little animation that kind of summarizes high-frequency spinal cord stimulation. Important point on there that I forgot to mention is that you have the opportunity to trial out this kind of a therapy before you commit to it, meaning that you have a temporary device placed for about 7 days, connects to an external battery, and you can try this out for yourself, which is kind of rare in medicine that you can test drive something before committing to it. And if you find that this is pretty substantially effective in reducing your pain, life-changing, then we can talk about a permanent system like this. Thank you. Do you guys have any questions?
How long, if you said something about permanent, so how long is?
Sure. So the batteries or the pulse generators can kind of vary based on the energy requirements that are being utilized. So that can vary patient to patient. But generally, with this kind of a therapy, the battery can last up to 10 years in duration. So it's very similar to cardiac pacemakers in a sense, but a little bit longer because this is something that can be recharged on a kind of, depending how much energy is being used. It could be every couple days, it could be every couple weeks. Good question.
Is it covered by insurance?
Yes, so this kind of a therapy is covered by Medicare, Medicaid, a lot of commercial payers as well. And again, it's not something that's a first treatment option for a lot of people with chronic back and leg pain, but it can be a quite effective one if they feel more conservative treatment options. Yes?
You said leg pain, does that include your knees as well?
Yeah, so it does include the entire leg, but in particular, what we're looking at for leg pain are signs of neuropathic pain or nerve-related pain. So typically that'll differ from more the kind of arthritic knee pain that's more achy and stiff. The nerve-related pain usually kind of feels more like a burning or pins and needles sensation. You have some changes in sensation to light touch. So we're really looking for that particular type of pain in the lower extremities.
Excellent presentation. Thank you so much. I would ask Dr. Vaughn to come to the panel. If you guys have any questions to any of our respected speakers, Dr. Sagarwala, Kurt, and Dr. Vaughn, would like to take any questions? All right, I have a question for Dr. Vaughn. Dr. Vaughn, in your expertise as a neurologist and pain physician, you hold a very unique position because you're involved in the diagnosing stage of the problem and the treatment. So when you cannot pinpoint an etiology for pain, being a pain physician, like how do you navigate this? Like do you feel you're more empowered to treat pain because you have this neurology, great knowledge and background, and like what's your like take home messages, like with the value that our neurologist department has, whether it's a test or like certain diagnostic study that you would recommend?
So I would say that we all learn, diagnosis in our pain fellowships, but I would say that the reverse is not true. In my neurology residency, we learned very little about how to treat headache syndromes, radiculopathy, et cetera, outside of medications. Most likely because, neurologists aren't certified to do these interventions. But I think that we weren't taught in residency when to say unfolding. So when to just say, okay, this may be something I now need to refer to pain management. When you mentioned previously that we would like to be involved early, most neurologists don't move in pain management early enough, in my opinion. So in that sense, sometimes I get patients who are just referred to see neurology in general, and they're surprised that my approach is very different than if you saw, like a general neurologist who wasn't board certified in interventional pain.
So I think we at Insight have a unique opportunity by having double board certified in both neurology and pain management. So Dr. Vaughn can really add assets and value in diagnosing difficult, incurable pain that people cannot figure out. So thank you, Dr. Vaughn, for being with us, and I really appreciate everything you do for our pain program and our patients. Does anybody have a question for Kurt? If you don't, I do. Kurt.
Yes, ma'am.
Oh, there is a question. Excellent. I don't know if this will stand. You wanna?
I was just gonna ask you, you mentioned earlier about the headaches and, like, what a period of time do you know it's chronic?
Oh, for chronic headaches?
Yeah, chronic headaches and neck also you mentioned.
Yeah, so for pain in general, we say like if you have pain over 3 months, we will call it chronic. For headaches, I would say if you have more than like 14 headache days per month, so you may have a bad headache that lasts for a week each time, you may have headaches that are clustered around, some event, your menstrual cycle, you work, like you have shift work disorder or something like that. So if you're having more than 14 headache days a month, I would definitely say you have a severe chronic headache syndrome, but you don't need to wait until it gets that bad to come and speak to somebody about it.
Questions for Kurt? All right, Kurt, I really appreciate what you do in physiotherapy for inpatient. However, I was wondering if we have plans for inside to expand our outpatient physiotherapy. Right now, when I send people for physiotherapy, was a critical component of the pain management. You
Yes.
guys have a long waiting list.
I'm-
So what's the plan?
My supervisor left. Unfortunately, we have been interviewing a lot of therapists. However, it's more of like human resources. We are waiting for them to provide the offer. And unfortunately, there's always been a delay wherein the therapists that we have interviewed have already found like other jobs. So it's ongoing. We're still doing interviews.
Excellent. Well, that's good to know. So go ahead, please. Do you think you're loud enough or you? I'm loud enough. All right. Your question is for who?
It's for Dr. Vaughn. So Dr. Vaughn, I wanted to know how often should you get the injections? I've had injections before. So like, do you revisit and come back again to get them again? And how often should we have that done in order to guarantee comfort and so forth?
I think that everyone's approach is probably different. Traditionally, before we would say, we do a series of 3. At this point, for myself, I say, let's just do 1 and see how it goes. We reconvene after 2 weeks. That's when the steroid is generally at its maximum effect. And if you say, this was pretty good, but I think we can get closer to the finish line, I say, let's try another one. If you say, I'm feeling great, I say, let's ride it out and see how long it will last. Ideally, we would like the steroid to last at least for 3 weeks.
Okay. Thank you. Excellent. Any other question? You're happy and you're satisfied, you're fulfilled with knowledge, you're empowered to treat pain? Well, if this is all your questions, I would love to thank all of you, and I hope to see you more often with other events too. Thank you, Dr. Vaughn, for your valuable talk and input. Thank you, Dr. Sagarwala. Thank you, Kurt. It was great teaming up with you, and I hope that we will have more opportunities to engage with our healthcare system and our community. Thank
This
you.
was Dr. Jabri's passion